Welcome to our video on viral hepatitis. Let's get started. In this video, we'll go through an introduction to viral hepatitis, followed by a review of all of the hepatitis viruses, including hepatitis A, B, C, D, and E. Hepatitis means inflammation of the liver parenchyma. It can be caused by both infectious and non-infectious disorders. The most important infectious causes are viral hepatitis A, B, C, D, and E. On the other hand, common non-infectious causes include alcoholic hepatitis, autoimmune hepatitis, and metabolic disorders affecting the liver. Our topic of discussion in this video will be viral hepatitis A to E. Before we begin, let's have a look at this table which summarizes the key features of hepatitis viruses A to E. The predominant mode of transmission for hepatitis A and E is the fecal-oral route. These two viruses are naked RNA viruses. Recall from step 1 that naked viruses, which lack a lipid envelope, are generally resistant to harsh environments, such as gastric acid. And so many of these viruses are transmitted via the fecal-oral route, as is the case with hepatitis viruses A and E. In contrast, enveloped viruses are more easily destroyed by harsh environments, such as gastric acid, which dissolves their lipid bilayer, and generally have to remain in body fluids to be transmitted from person to person. Hepatitis B, C, and D are enveloped viruses, and therefore their predominant mode of transmission is parenteral. You can use the mnemonic 8 to remember the fecal-oral transmission of hepatitis A and E, since eating is related to the GI tract. Secondary hepatitis B is predominantly spread by sexual transmission and perinatal transmission. These modes of transmission are less common with hepatitis C, which is predominantly spread by sharing contaminated needles among IV drug abusers. Nonetheless, any kind of fluid sharing has the potential to spread both of these viruses. Hepatitis D, as we'll discuss later, is dependent on the presence of hepatitis B in order to infect the liver, and hence shares many characteristics with hepatitis B. So it has the same mode of transmission as hepatitis B, that is, parenteral, including sexual transmission. Hepatitis A and E mostly cause an acute self-limited hepatitis, which clears on its own and does not progress to chronic or carrier states. They rarely cause fulminant hepatitis in healthy individuals. Of note, hepatitis A can be fulminant in patients with underlying liver disease, and hence all patients with chronic liver disease should be vaccinated against hepatitis A. Hepatitis E has a high likelihood of being fulminant in pregnant patients. Hepatitis B is also a majority. The majority of the time, hepatitis B is also self-limited and clears on its own. However, it can progress to a chronic infection in a subset of patients about 5 to 15% of the time. With hepatitis C, in contrast, the majority of patients progress to chronic infection. As mentioned earlier, hepatitis D mostly behaves the same way as hepatitis B. Therefore, when it's a co-infection with hepatitis B, it usually causes an acute self-limited hepatitis, just as is the case with an acute isolated infection of hepatitis B. And when it causes a superinfection over a chronic hepatitis B infection, it usually doesn't resolve and progresses to a chronic infection. Also note, the majority of cases of hepatitis B and C are subclinical. Hence, it's not usual for a patient to have a chronic infection with these viruses and may be completely unaware of it. The mainstay of diagnosis for viral hepatitis is serological tests. We'll discuss these in detail with each individual virus. The last thing to note here is that when hepatitis viruses B, C, and D are a superinfection with hepatitis B, it can result in grave sequelae, including cirrhosis and hepatocellular carcinoma. This is not a problem with hepatitis A and hepatitis E, which only cause acute hepatitis. Now let's review each type of viral hepatitis one by one, starting with hepatitis A. Hepatitis A is caused by hepatitis A virus, abbreviated as HAV. It's a naked RNA virus, most commonly transmitted through the fecal-oral route. So, consumption of contaminated food and water is a major risk factor and also a good clue to the diagnosis. It can also have occasional sexual or bloodborne transmission as well. It causes an acute self-limited hepatitis. The common symptoms of an acute hepatitis are fever, anorexia, malaise, jaundice, and right upper quadrant pain. A patient may only have one or two of these symptoms. Hepatocyte injury causes leakage of intracellular enzymes, including alanine and aspartate aminotransferases, and aspartate aminotransferase, as well as the leakage of bilirubin. Hence, labs will show raised serum ALT, AST, and bilirubin. In viral hepatitis, ALT is raised higher than AST, as opposed to alcoholic hepatitis, in which the AST is higher than the ALT. As we already discussed, it may cause fulminant hepatitis in patients with chronic liver disease. Otherwise, it's usually self-limited and has no carrier state. The diagnosis of acute hepatitis A is made by demonstrating high titers of anti-HAV IgM antibodies. Like in any other infection, IgM antibodies are generated during an acute infection only. Over time, these are replaced by IgG antibodies. Hence, the presence of IgG antibodies indicates immunity, either due to past exposure or previous vaccination. Management of acute hepatitis A is supportive, as this infection is mostly self-limited and resolves on its own. This generally includes analgesics for pain relief, bed rest, IV fluids, and antiemetics for patients with nausea and vomiting. To prevent outbreaks, several measures are now recommended. These include routine vaccination of children, healthcare workers and travelers, and the vaccination of patients with chronic liver disease, as well as patients with HIV infection, since these patients are at a risk of hepatic decompensation. Also vital is the post-exposure prophylaxis of all household members and sexual contacts of the infected person. Post-exposure prophylaxis is to be given within 2 weeks of exposure. People above the age of 12 months are to be vaccinated. Generally, for people that are less than 40 years old, the hepatitis A vaccine is administered, whereas for people who are older than 40, the hepatitis A vaccine is administered along with immunoglobulin. Immunoglobulin is used if prophylaxis is needed in infants, that is, those are less than 12 months of age. This is done to avoid the potential interference of the vaccine with maternal antibodies in this age group. All right, let's try a question. A 27-year-old female is diagnosed with acute hepatitis A infection. She has 2 sexual contacts, person X and person Y. A serological report of person X is as follows: anti-HAV IgM negative, anti-HAV IgG negative. A serological report of person Y is as follows: anti-HAV IgM negative, anti-HAV IgG positive. Which person, X or Y, requires post-exposure prophylaxis? All right, this female has a confirmed case of hepatitis A infection, and therefore all of her close contacts, such as her sexual contacts, should be given post-exposure prophylaxis if there is no evidence of immunity. To determine which of her sexual contacts needs prophylaxis, let's evaluate their serological reports. Firstly, both have an anti-HAV IgM negative serological test, indicating an absence of an acute infection. Secondly, person X is anti-HAV IgG negative. Recall from our previous discussion that IgG antibody indicates immunity, and hence we can safely say that person X does not have immunity against hepatitis A and is susceptible to contracting this infection from our patient. Therefore, he or she requires vaccination. Person Y, on the other hand, is anti-HAV IgG positive, meaning he or she is already immune to this virus either due to a past infection or vaccination, so this individual does not require post-exposure prophylaxis. So the answer to the question is person X. Next, let's discuss hepatitis B. Hepatitis B is caused by hepatitis B virus, abbreviated HBV. It's an enveloped, partially double-stranded DNA virus. The most prominent mode of transmission is the parenteral route, particularly sexual contact, such as IV drug use and contaminated blood transfusions are also common. Perinatal transmission of the virus during delivery is also a potential mode of transmission. As we already discussed, the majority of the time hepatitis B infection causes an acute self-limited hepatitis. A duration of less than 6 months is considered acute hepatitis. The majority of cases are asymptomatic and are therefore termed subclinical. Symptomatic cases present the same way as other hepatitis infections, such as with a fever, malaise, anorexia, jaundice, and elevated liver function tests, or LFTs. Some people develop chronic infection. Chronic infection, by definition, is viremia for more than 6 months. When infection is acquired during adulthood, the rate of chronicity is less than 5%. In contrast, hepatitis B infection acquired perinatally almost always progresses to chronic infection. The continuous inflammation and damage caused by a chronic hepatitis B infection can eventually give rise to cirrhosis, a term for end-stage liver fibrosis. Chronic inflammation also increases the risk of cancerous mutations, and therefore cirrhosis by any cause is accompanied with an elevated risk of hepatocellular carcinoma. However, in hepatitis B infection, hepatocellular carcinoma occurs both because of cirrhosis and because HBV itself is an oncogenic virus. The diagnosis of both acute and chronic hepatitis B infection is dependent on serology. To understand serology, let's review all the important antigens and antibodies related to hepatitis B. Here's an image of the hepatitis B viral particle. There are 3 antigens that we use in serologic studies. These are hepatitis B surface antigen, which is present on the envelope, abbreviated as HBsAg, the hepatitis B core antigen, which is part of the nucleocapsid, and this is abbreviated HBcAg, and hepatitis B E antigen, which is also present near the nucleocapsid and is abbreviated HBeAg. Starting with hepatitis B surface antigen, this is a glycoprotein antigen present on the surface of hepatitis B virus. The presence of this antigen in the circulation indicates infection with hepatitis B, whether acute or chronic. The body's immune system generates antibodies against hepatitis B surface antigen. These are known as hepatitis B surface antibodies. They're protective antibodies against the hepatitis B virus, which are highly efficient in eradicating and preventing the infection. These are used in vaccination as well. Hence, their presence indicates immunity against hepatitis B. This immunity can be both due to a resolved infection in the past or vaccination. Hepatitis B core antigen is part of core protein and is sequestered inside the virion and not released into the blood. Hence, we cannot detect it in the blood. But the antibodies against this core antigen, known as hepatitis B core antibodies, are very important. First of all, this core antibody is not protective, and therefore its presence does not indicate immunity, meaning that one can have these antibodies and still be infected with the virus. Instead, this antibody marks acute infection with hepatitis B and is a very useful marker early in the infection, when the infected patient has not yet started to make the protective surface antibodies against the virus. Hence, IgM core antibodies indicates an acute infection and it converts to IgG over time. In addition, IgM core antibody may be the only marker of hepatitis B infection during the window phase, which is the time interval during which both hepatitis B surface antigen and antibody are at undetectable levels. Alright, coming to hepatitis B E antigen. This is also produced by the core gene, but unlike the core antigen, it's released into the blood and it's detectable. It's only released during active viral replication when the viral load is also very high. Therefore, its presence indicates active infection, meaning ongoing hepatocyte damage, as well as a high viral load, meaning high infectivity or transmissibility. So directly opposed to this, hepatitis B E antibody indicates an inactive infection and low infectivity. Alright, so when a patient contracts hepatitis B virus, they become positive for HB surface antigen, and they remain positive with this antigen until and unless they resolve the infection. You can see here that HB surface antigen is present in both an acute infection and a chronic infection, whether active or inactive. It basically marks the presence of the virus in the body. The window phase is the only time during which HB surface antigen can come out negative, despite the presence of an infection. This is because during this time, HB surface antigen and surface antibody are present in equal amounts and bind to each other, making antigen-antibody complexes, leaving no free antigens or antibodies to be detected by lab tests. However, the presence of HB core IgM antibody during this period distinguishes it from an uninfected person. Therefore, we must look for HB core IgM antibody when testing patients with suspected hepatitis B, since it may be the only marker detected during the window phase. So during an acute infection, we'll show HB surface antigen positivity and HB core IgM antibody positivity. Since acute infections are always active, HBe antigen is also positive during this time. The surface antibody and E antibody are negative, since the patient has not yet developed immunity against this infection. HB core IgG is also negative, because it's an early stage and seroconversion takes time. Notice how HB core IgM disappears after the acute stage and is replaced by HB core IgG, whether the infection gets resolved or progresses to a chronic active or inactive infection. Alright, so after the acute stage, either the infection gets resolved or progresses to chronic infection. If the infection gets resolved, the markers of viral presence, meaning the antigens, disappear, while the markers of immunity, the HB surface antibody, appears. IgM has now been replaced by IgG core antibody, and you may also see HBe antibody positivity. So we highlighted the significance of HB core IgM antibody as a marker of acute infection, which is true even in the apparent absence of HB surface antigen. But what is the significance of IgG core antibody despite it providing no immunity? Well, it differentiates a person with resolved infection from a vaccinated person. Note here that during vaccination, we administer only the surface antigen, and therefore the body generates only surface antibodies and not core antibodies. Hence, a vaccinated person has HB surface antibody positivity and HB core antibody negativity, whereas a person with a resolved infection has both HB surface antibody and HB core antibody positivity. Don't worry too much about HBe antibody because it may wane over time and doesn't reliably differentiate between a resolved infection and a vaccinated status. All right, coming to chronic infection. So if the case progresses to chronic infection, the HB surface antigen remains persistently detectable. There is no HB surface antibody, and the IgM core converts to IgG core antibody. If the infection is active, we see HBe antigen positivity. In contrast, if it's inactive, we see HBe antigen as negative, while HBe antibody as positive. Since an active infection indicates a high viral load and hence high transmissibility, we test for HBe antigen to estimate how likely it is for a chronically infected patient to transmit the virus to other people. All right, let's solidify this information with a question. A 37-year-old male volunteered to donate blood. What is his hepatitis B status based on his serological report shown below? HBsAg positive, HBsAb negative, HBcIgM positive, HBcIgG negative. This patient is positive for the HB surface antigen, and as we discussed, this is the marker of viral presence. So this patient is currently infected with hepatitis B. This is further reinforced by the absence of the HB surface antibody, clearly indicating a lack of immunity. Additionally, this patient's HB core IgM is positive, meaning he has an acute hepatitis B infection. So the answer is an acute hepatitis B infection. Needless to say, this patient is not eligible to donate blood. Now, let's have a different set of labs with the same patient. So this time, the HBsAg is negative, the HBsAb is positive, the HBcIgM is negative, and the HBcIgG is positive. Now this patient has a negative hepatitis B surface antigen. Recall that a negative hepatitis B surface antigen either means an absence of infection or a window period. So let's move on to the other markers to make this clear. The hepatitis B surface antibody is positive, indicating immunity. This means this person does not have a hepatitis B infection, so he is eligible for donating blood. Whether he's immune because of past exposure to infection or vaccination can be made clear by looking at the HB core IgG result. This is only positive in patients exposed to hepatitis B virus, and hence this patient's immunity comes from a past exposure to hepatitis B virus. So the answer is resolved infection. All right, let's change the results again. Now we can see that the HB surface antigen is positive, HB surface antibody is negative, the HBcIgM is negative, and the HBcIgG is positive. So in this case, the HB surface antigen is positive, indicating a current infection. This is further reinforced by the negative surface antibody, showing an absence of immunity. The absence of IgM core antibody and the presence of IgG core antibody indicates a chronic infection. Although chronic infection is defined as HB surface antigen positivity for more than 6 months, we can still safely say that this patient has had a hepatitis B infection for some time based on seroconversion to IgG. So the likely status of this patient is chronic infection. All right, now let's move on to management. Just like with hepatitis A, an acute infection with hepatitis B is also managed by supportive treatment, such as analgesics, bed rest, as well as IV fluids and antiemetics as needed. However, persistent infection needs specific treatment to reduce the risk of progression to cirrhosis and hepatocellular carcinoma. Treatment options are the antiviral agents, nucleoside or nucleotide reverse transcriptase inhibitors. An abdominal ultrasound should be obtained every few months to screen for hepatocellular carcinoma. Hepatitis B vaccination plays the most important role in the prevention of hepatitis B infection. Vaccination is done with recombinant HB surface antigen, which stimulates the generation of hepatitis B surface antibodies in the recipient. It's indicated routinely in all children, people at high risk of acquiring infections such as healthcare workers, and household and sexual contacts of infected people, immunocompromised patients, diabetics, and all patients with chronic liver disease. The non-responder rate is 5 to 10%. These people may need to undergo a repeat hepatitis B vaccination, especially if they have a high risk of exposure, such as healthcare workers. Therefore, post-vaccination serologic testing is recommended 1 to 2 months after completion of vaccination for healthcare workers with a high risk of exposure. HB surface antibody titers of less than 10 indicates an inadequate response. Additionally, hepatitis B vaccination is also the mainstay of post-exposure prophylaxis of hepatitis B with or without hepatitis B immunoglobulin. For post-exposure prophylaxis of hepatitis B infection, first of all, the vaccination status of the exposed individual has to be determined. If the exposed individual is vaccinated with documented adequate antibody response, defined as HB surface antibody titer of greater than 10, no further intervention is required, regardless of the source of the patient's HB surface antigen status. For vaccinated individuals with an inadequate antibody response, that is a hepatitis B surface antibody of less than 10, we check the source of the patient's HB surface antigen status. Management then depends on the source of the patient's HB surface antigen status. If the source of the patient's HB surface antigen is positive or unknown, post-exposure prophylaxis with both hepatitis B immunoglobulin and hepatitis B vaccine are indicated. On the other hand, if the source of the patient's HB surface antigen is negative, only the hepatitis B vaccine is administered. The same is true for unvaccinated individuals. The management depends on the source of the patient's HB surface antigen status. If positive or unknown, both hepatitis B immunoglobulin and hepatitis B vaccine are indicated, whereas if negative, only the hepatitis B vaccine is indicated. Okay, now let's move on to discuss hepatitis C. Hepatitis C is caused by the hepatitis C virus, abbreviated HCV. It's an enveloped RNA virus transmitted via the parenteral route. The most common mode of transmission is IV drug use. Unlike hepatitis B, sexual and perinatal transmission are much less common. Also, people who've had blood transfusions prior to 1992 can also have hepatitis C infection, since routine screening of blood products for hep C was only introduced after that. Similar to hepatitis B, the majority of cases are subclinical, when acute clinical features are fever, malaise, jaundice, right upper quadrant pain, and elevated LFTs, just like in any acute viral hepatitis. The majority of cases progress to chronic hepatitis C infection. This is because, in contrast to hep B, which is a DNA virus, hep C is an RNA virus. Recall from step 1 that RNA replication has a much less strict proofreading process compared to DNA replication. And that's why hep C viral replication has a high mutation rate. The continuous changes in the antigen sequences therefore prevents generation of a protective antibody response. This is also the reason why a vaccine is not available for hep C. Therefore, the majority of people cannot clear the infection, and it progresses to chronic hepatitis C, accompanied by an elevated risk of cirrhosis and hepatocellular carcinoma. Unlike hep B, this elevated risk of cancer is not due to viral nucleotide integration into host DNA, but merely due to the continuous inflammatory damage going on in the liver. The diagnosis of hep C is a two-step process. First, we screen with anti-HCV antibody. Since the antibody is present both in current infections and resolved infections, a positive antibody test has to be confirmed by HCV RNA PCR, which directly detects the hepatitis C RNA. Positive anti-HCV antibody as well as positive HCV RNA PCR confirm the diagnosis. On the other hand, if the positive anti-HCV antibody test is followed by a negative HCV RNA PCR, this indicates a resolved infection or a falsely positive antibody test. This is because PCR detects even small quantities of hepatitis C RNA, so a negative PCR test rules out current infection. Again, to reduce the risk of progression to cirrhosis and hepatocellular carcinoma, specific treatment is required to eradicate a chronic hep C infection. Direct-acting antiviral agents are the current treatment of choice. These target specific parts of the HCV replication cycle, such as RNA replication and protein assembly. Examples include sofosbuvir, cimeprevir, and ledipasvir. Interferons and ribavirin are less commonly used now due to side effects. Serial ultrasounds of the abdomen are recommended to monitor for hepatocellular carcinoma. And as we already discussed, no vaccine is available, so prevention is largely dependent on avoiding risky behavior, such as sharing contaminated needles. Okay, let's move on to hepatitis D. Hepatitis D is caused by hepatitis D virus, abbreviated HDV. It's a defective RNA virus, called so because it cannot cause an independent infection. It requires the presence of hepatitis B virus for its replication and entry into cells. Therefore, it's only seen as a co-infection or a superinfection with HBV. So similar to hep B infection, it has parenteral transmission, such as sexual and bloodborne. As we discussed earlier, a co-infection with hep B is similar to an isolated infection with HBV. That is, most cases self-resolve after causing acute hepatitis. On the other hand, a superinfection of hep D virus over a chronic HBV infection usually continues as a chronic infection. Both co-infection and superinfection are characterized by higher mortality and morbidity compared to an isolated HBV infection. In fact, a patient with chronic stable Hep B can go into sudden hepatic decompensation when superinfected with Hep D. The diagnosis is made by detecting anti-HDV antibody and/or HDV RNA. There is no specific treatment for Hep D, so it's just treated as if the patient had hepatitis B. Liver transplantation is done if fulminant hepatitis occurs. All right, the last topic is hepatitis E. This is caused by the hepatitis E virus. It's a naked RNA virus transmitted via the fecal-oral route. So there is increased risk of infection with the consumption of contaminated food and water. It causes a self-limited acute hepatitis in healthy individuals. However, it's known for having a significantly high mortality rate in pregnant patients. The diagnosis is made by detecting anti-HEV antibodies, and the treatment is supportive, including analgesics, IV fluids, and bed rest. All right, let's wrap up with a final question. A 35-year-old female is volunteering for a blood transfusion. Her blood is screened for hepatitis B and C infection. Test results show a negative hepatitis B surface antigen, a positive hepatitis B surface antibody, a negative hepatitis B core antibody, and a negative anti-HCV antibody. What is true about her eligibility to donate blood? A, she is eligible because her blood is clear of hepatitis B and C infection. B, she is not eligible because she has a hepatitis B infection. C, she is not eligible because she has a hepatitis C infection. Or D, needs further investigation. Okay, so to declare her as eligible or ineligible to donate blood, we need to correctly interpret her serological test results. She is negative for HB surface antigen and positive for HB surface antibody. This clearly indicates that she is immune to hepatitis B and is not currently infected with it. Also notice that her HB core antibody is negative, meaning that she has not been exposed to hepatitis B and her immunity must be coming from a previous vaccination instead. Recall from our table that a vaccinated individual is HB surface antigen negative, HB surface antibody positive, and core antibody negative. Now, what about her hepatitis C status? Well, her anti-HCV antibody is positive, indicating that she has been exposed to hepatitis C virus. But since a majority of people do not clear Hep C without treatment, we need to do a PCR test next to look for hepatitis C RNA and to confirm or exclude the presence of a Hep C infection. It's not possible to tell her Hep C status without the HCV RNA PCR test. So the correct option is D, needs further investigation. All other options are clearly wrong because it's not possible to declare her as eligible or ineligible without first confirming her Hep C status. And that concludes our section on viral hepatitis.